our presenter will be Professor Mario from the USCE. He is a staff physician at the Cleveland Clinic. He is an associate professor of medicine and director of PBL case development and holds the Catherine and E.D. Lozick Chair in Endocrinology and Metabolism, and he will present subclinical thyroid disorders.
Good day to everybody in Egypt. I'm really glad that I can do this again. I have not presented in this conference for quite some time. I thank you, organizers, especially Professor Amara, who is my good friend, who invited me to do this. I'm going to today talk about subclinical thyroid disorders. And this is an important topic that, is becoming more and more actual in the last couple of years, at least here in the United States. So we'll start with some definitions of the subclinical thyroid disorders. So if you have elevated TSH, higher than normal range, but normal thyroid hormone levels, you are said to be having subclinical hypothyroidism. Now, there are some other definitions in the literature. So some authors consider patients with high normal TSH, so normal TSH, but abnormal response to TRH, thyroid releasing hormone, as having subclinical hypothyroidism. So there's a little bit of difference in the definition, but it's important to remember that there is some people who consider even having the TSH within normal range to be having subclinical hypothyroidism. And of course, on opposite side, we have individuals with a TSH that is lower than normal, but with normal thyroid hormone levels, and these people would be said to have subclinical hyperthyroidism. Now, when you're talking about TSH, first we need to know, figure out what is the normal TSH range. Now, most commonly used assays in USA will have a slight difference in range. So in the Cleveland Clinic, we use the one that actually has a range of 0.4 to 5.5 microunits per milliliters. But there's other commercial labs, like we have a Quest over here, who has actually slightly different than normal ranges, reference ranges, 0.47 to 4.2 microunits per milliliters. So not all the assays are the same. So the lower limit of the normal range, it is somewhat variable, but relatively well established between 0.27 and 0.4. Now the upper level normal range is controversial, and I'll show you why it is. So this is actually plot of the TSH range values for the people in NHANES 3. So those are the healthy people with no known thyroid disease, and they looked at their TSHs. And as you can see, these values are not normally distributed. Actually, they're skewed, and there's more people toward the lower end of the range. And you can see 1.67 was actually a group that had the most people. And as you can see, a very small number of people are over 3.3 over here. So there's no normal distribution of the TSH. Why is that? We don't understand. Is it possible that some of these people have an incipient thyroid disorder? These people did not have checking of their thyroid autoantibodies, so we don't know about it, but they were clinically euthyroid. So interesting, in this group of 13,000 people, median TSH was 1.38. So 50% of the people were below 1.38 and 50% over 1.38. Now, consensus conferences done by American Thyroid Association, American Association of Clinical Endocrinologists, and Endocrine Society accepted those NHANES 3 derived normal ranges. But National Academy of Clinical Biochemistry actually proposed that the normal reference range would be from 0.4 to 2.5 microunits per milliliter. That's your upper level is much, much lower. And the American Association of Clinical Endocrinologists proposed to count as a reference range 0.3 to 3.0. So there is this effort to push the upper side of the reference range to the lower levels. Now, but if you do this, there will be some practical considerations. If you lower this from 5 to 2.5, this changes prevalence of subclinical hypothyroidism from 4.6% to 20% in one of the studies. So that would actually put a lot of people in this category. So we don't know what is the good way to think about it. Now, TSH does varies over time. If you have an abnormal TSH, you should not jump on it right away. You should be rechecking it in 3 to 4 months. to confirm that elevation is persistent. So the one elevation of TSH doesn't mean much because transient elevations are not uncommon in this population. So there's TSH elevations that are not associated with hypothyroidism. For example, recovery from non-thyroidal illness, CQ thyroid syndrome in a recovery period. Adrenal insufficiency, people will sometimes have high TSH. Treatment with metoclopramide and domperidone. In the cases of TSH secreting adenomas, you're going to have slightly high TSH, but hyperthyroidism. Cases of thyroid hormone resistance, and then sometimes there's assay variability. You always have to count on an error in a lab. And then there's also such thing as a late evening pulse in TSH secretion. So this might be important in a hospital when people get blood drawn in the afternoon for TSH and suddenly TSH is slightly elevated. Of course, decreased TSH also could be seen with conditions that are not associated with hyperthyroidism. So that is also important to keep in mind. So which one of those? For example, central hypothyroidism, people with pituitary tumors and the radiation or anything, hypophysitis, they will have low TSH, but they will be hypothyroid. Non-thyroidal illness, again, CQ thyroid syndrome, in the beginning stages, there will be lowering of TSH in some of these patients. Use of the glucocorticoids will reliably decrease TSH and also dopamine use. And then recovery from hyperthyroidism. People with Graves' disease will sometimes be left with low TSHs for a prolonged period of time. Actually, there is some studies showing that 10 to 15% will never normalize TSH. And then in early pregnancy, where the HCG, which is an analog of TSH, will stimulate the thyroid, cause the mild hyperthyroidism, and TSH would be low. And that is very important. And when you're dealing with the pregnant women, you should be using actually trimester-specific reference ranges for the TSH, not normal reference ranges. On the other hand, even TSH over 20, which is pretty high, can be associated with normal thyroid hormone levels when you measure them. So you have to be careful assessing these patients. Now, trying to identify individuals with mild thyroid disorder based on a search for the symptoms have not been successful. The reason for this is because the symptoms are very, very non-specific. On a hypothyroid side, you have tiredness, feeling cold, constipation, dry skin. A lot of people will have those symptoms. On the opposite side, hyperthyroidism, increased anxiety, a little bit of tremor, feeling hot, not being able to sleep, a little bit of diarrhea. I mean, those are also symptoms that are not very specific. But, so trying to just look at the patient and decide if they have healthy thyroid is not been successful. And then, so really you have to use the laboratory measures to see if there's thyroid in a normal range or not. Now, if you are having a patient who has the symptoms that would be suggestive of the thyroid disorder, and then you're checking them and you find them normal, that is not subclinical. That is a clinical disorder, regardless of how severe the laboratory abnormality is. So you should be diagnosing subclinical hypothyroidism in patients who do not complain of symptoms associated with hypothyroidism. So you check them routinely, you find elevated TSH, they're still not complaining of anything, that is subclinical disorder. But if the patient, as I already said, if a patient complains of the symptoms and you find abnormality, that is not considered subclinical. So in my opinion, if you find it elevated TSH, you recheck it after 3-4 months, maybe sometimes earlier. I would sometimes do it in even as early as 4 weeks because patients are impatient. And if it's elevated, I think the treatment should be seriously considered in such a patients. A reason for this is actually because the treatment is cheap and it's not harmful. So if you find somebody with a subclinical hypothyroidism, you treat them, 10-15 days later, they know if they have clinical improvement in their symptoms. And if they don't, you can stop it, no harm done. How you do this? Well, first of all, if the TSH is 6 or 7, you shouldn't bring it down to 4. You should actually bring the TSH to less than 2.0 microunits per milliliter, and then assess therapeutic effect. If benefit is derived, treatment should be continued. With this approach, you have probably 50-50 chance to really help those patients because many of them will admit to improvement in the symptoms. Okay, so in, what do you do? If the patient has a TSH that is actually from upper part of the normal range to the 10 microunits per minute with normal TSH levels, with no symptoms that could be explained by hypothyroidism. I mean, those are the people who truly fit this category of subclinical hypothyroidism. So TSH from upper normal to 10. And this is where the controversy is. If the TSH is higher than that, most professional organizations say attempt to treat. Here in this area, this is where you're dealing with the kind of gray area where there's no clear guidance or recommendations for treatment or not treatment. Now, if you consider this definition of the thyroid disorder to be subclinical, then what is the prevalence? Well, the best study ever found was actually a Wickham survey done in England, where they were actually following people for more than 20 years. And in the beginning of the Wickham study, there was a prevalence of the subclinical hypothyroidism in men of 2.8%, women 7.5%, but women who were older than 60 had this prevalence of 11.6%. So as you can see, there's more in women, and older you get, more it is. In NHANES, the study that I already shown, in prevalence in 16,500 patients, there was a 4.3% prevalence of the subclinical hypothyroidism. So this is not uncommon situation. In Colorado thyroid disease prevalence study, 25,000, actually almost 26,000 patients, overall prevalence was 9.5%, which is very, very high. 18 to 24 years old were very young people, 4%. Women over 74, 22%, so almost 1 in 4. And men over 74, 16%. So that is a very, very common thing. Now, they found in this, when they studied that there is increased prevalence in patients who have other autoimmune endocrine disorders, diabetes mellitus type 1, Schmidt syndrome, and celiac disease. And most of these people were actually having subclinical hypothyroidism due to the presence of the Hashimoto's thyroiditis, so another autoimmune disorder. So what is the etiology? Well, there's some common cases. Subclinical hypothyroidism could be iatrogenic because people are kind of afraid to treat properly hypothyroid patients. So, for example, in patients with coexisting heart disease, sometimes people will keep the TSH higher to kind of prevent arrhythmias. I think that is a wrong thing to do, but people do that. In people with malignant diseases, there's some evidence that keeping the TSH slightly higher in reference range will actually cause the people to live longer and have better survival times. Of course, in patients with poor compliance, I see this every day, and in patients who are taking medications inappropriately because there will be interference with absorption. So people taking the thyroid hormone especially with iron, calcium, and magnesium, frequently will have decrease in absorption and elevated TSH. Now, and I will warn routinely my patients about not taking thyroid hormones with those preparations. Of course, then the biggest group is group who has Hashimoto's thyroiditis. That's the most common cause. About 54% of the patients who are diagnosed with subclinical hypothyroidism have positive antibodies for Hashimoto's thyroiditis. So either thyroglobulin antibodies or microsomal thyroid peroxidase antibodies, as they're also known. United Kingdom study found antibodies in 67% of women and 40% of men with subclinical hypothyroidism. So this spontaneous hypothyroidism subclinically is almost, it's a majority of cases caused by Hashimoto's thyroiditis. And then also some people will have postpartum thyroiditis. That's another cause of subclinical hypothyroidism. And then medications. Taking medications, some of the medications are associated clearly with development of the thyroid disorders, and in some cases those are going to be subclinical. Most commonly, we see this with amiodarone and lithium, interferon, which is actually less used nowadays, sunitinib or sorafenib, which are actually tyrosine kinase inhibitors used in the treatment of malignant diseases. And actually what's missing in this list is the checkpoint inhibitors, the whole new group of medications used in treatment of malignant diseases. They are particularly prone to cause hypophysitis, but also thyroid disorders. So those would be the common causes. And then, of course, sometimes we have people with partial thyroidectomy. Most of them will stay euthyroid, but some of them will just slip into the subclinical hypothyroidism. People with head and neck radiation, usually because of the malignancy. Patients after radioactive iodine ablation of Graves' disease. Although the goal of this patient is to make him fully hypothyroid, sometimes they will stay in subclinical hypothyroidism. So what are the clinical consequences of subclinical hypothyroidism? First of all, some of these people will progress to overt hypothyroidism. Depending on the literature, it could be between 2% to 5% yearly. I think average is about 4%. However, 10% of these patients may eventually normalize. So higher the initial TSH, higher the risk of progression. Positive antimicrosomal antibodies, or thyroid peroxidase antibodies, higher the risk of progression. If again, in a Wickham survey, which they followed the people for 20 years, they looked at it for the progression. So there were 27% risk of developing full-blown hypothyroidism if antibodies were positive, 33% risk if the TSH was higher than normal in the beginning of the study. So after 20 years of follow-up, 55% if the TSH was higher than normal and antibodies were positive, but only 4% if the TSH was normal and antibodies were negative. So both high TSH and antibodies were risk factors. So interesting. This is actually the chart from that study, and it's very, very interesting for two reasons. You can see that higher the TSH, the higher the risk for development of hypothyroidism. But inflection points starts at about TSH of 2 milliunits per liter or microunits per milliliter. And that's regardless if it's antibody positive or antibody negative. So this suggests that there is there would be justification to pull the TSH upper edge of the reference range of TSH to lower than 5.5. Now, what are so one of the risks is developing a full-blown hypothyroidism. But even if you remain in subclinical stage, there is some increased risk for cardiovascular disease. So there's studies showing diastolic dysfunction in these patients, diastolic hypertension in this patient, increase in low-density lipoprotein, LDL, increase in high sensitivity CRP, and then some alteration in coagulation parameters and endothelial dysfunction, all pointing toward maybe increased cardiovascular risks. Now, those are relatively mild, but they're measurable differences. So is there really, real increased risk of the cardiovascular disease? Well, Wickham survey showed no association over 20 years with the coronary heart disease, dyslipidemia, or mortality. So if you stayed over 20 years in subclinical range, there was no increased risk for those three: coronary heart disease, dyslipidemia, and mortality. A Rotterdam study showed increased prevalence of atherosclerosis in these patients. So odds ratio is 1.7, so 70% increase in odds ratio. And the myocardial infarction, odds ratio 2.3, so 2.3 times higher risk in the women with subclinical hypothyroidism. Study showed mixed result, but population study were different. So you cannot really be sure exactly. The number of patients are usually small. You do the big study, you analyze a lot of people, but within this group of people, there's a small number of people with subclinical hypothyroidism, so it's kind of hard to assess those things. So, for example, in this one study done in the United States, there was 4,300 patients in the whole study, but only 281 of them had subclinical hypothyroidism. So it's very hard to then decide, is there real cardiovascular risk over a long time. So that's why this result varies. Some studies are showing increased risk, some not. There's some controversy in this field. So this is actually the Journal of Clinical Endocrinology and Metabolism published in 2001 article, written by the really giants in thyroid study, Chester Ridgway, who in the meantime passed away. and said subclinical hypothyroidism is mild thyroid failure and should be treated. So this is the opinion of really, gurus of the thyroid disease. But at the same time, look at this, it is the same volume of the magazine, Journal of Clinical Oncology and Metabolism. Right after this first article, there's another one saying the treatment of subclinical hypothyroidism is seldom necessary. So there's really no consensus if these people should or should not be treated. So again, what would we improve if we treat these people? So there's some studies showing some benefits. So for example, there's a benefit for the fertility. So if you look at the people who had the thyroglobulin and the antimicrosomal antibodies positive, they had a spontaneous miscarriage is 17% of the pregnancies compared to 8.4% if they're antibody negative. So it looks like this some positivity of the for the Hashimoto's thyroiditis might increase the risk of the miscarriage. They were looking at in another study on almost 25,000 pregnant women, and 2.3% of them had the subclinical hypothyroidism, and the risk for placental abruption and preterm delivery was 2 times higher than normal. So there may be some effect on pregnancy. There's another study looking at the 60. So they took the women who actually had several spontaneous miscarriages earlier in their life, and they were having positive anti-TPO thyroid peroxidase antibodies, and they were either treated by T4 or intravenous immunoglobulins. And 16 of them were treated with the T4 and 11 with the IV immunoglobulins. Turns out that those who were treated with the T4, they had delivery rate of 81.2%. Those with IV immunoglobulins treated, they have 54.5%. So not only that we have studies showing the increased risk of the miscarriage, preterm delivery, and placenta previa, we also have studies showing that treatment with T4 might improve those outcomes. There are some neuropsychiatric disorders that can be aggravated by hypothyroidism. So if the patient has subclinical hypothyroidism and depression, they will actually demonstrate that they have poor response to antidepressant medications. Patients who have subclinical hypothyroidism also have increased lifetime prevalence of depression, and women with subclinical hypothyroidism and goiter and increased size of the thyroid have increased rate of anxiety and depressive feature. So there is association of the thyroid function and the psychiatric illness. Mortality in the patients, again, there's a whole bunch of studies down here, looking at this. And as you can see, cardiovascular health study, 3,000 patients showed no increase in mortality. Meta-analysis showed increased risk in those older than 65 years of age. And several other studies showed actually increase in cardiovascular and all-cause mortality in people with subclinical hypothyroidism. So we actually did a study over here, and we examined about 6,000 patients who were high risk for cardiovascular disease. So they either had several risk factors, very high cholesterol, family history, atherosclerosis, or they already had heart attack. They were all enrolled in cardiovascular disease prevention program here in Cleveland Clinic. We have database maintaining data about it, and what we did, we divided the patient. Patients first. There was half of them in secondary prevention, so they already had a cardiovascular disease, and about half of them in primary with high risk, hypercholesterolemia, strong family history, and so on. All the cardiovascular risk factors were aggressively treated in these patients, and we went and looked if there's a TSH effect on their mortality. We divided them in those who were subclinically hyperthyroid, less than 4 TSH, 4 to 3, which we consider normal, over 3 to 6, we said mild subclinical hypothyroidism, 6 to 10, moderate subclinical hypothyroidism, and then more than 10 TSH, we consider them fully hypothyroid. Number of patients, we had 168 patients with subclinical hypothyroidism, over 4,700 patients who were normal, but the 1,200 patients who would consider to have mild hypothyroidism and subclinical hypothyroidism, and about 178 those with between 6 and 10, and only 79 patients were fully hypothyroid at that point. And then we had to exclude 14 patients because we didn't have TSH. There was no difference in between group in Framingham risk score, diabetes mellitus, LDL, LP little a, microalbuminuria. We corrected for and checked for many of these things. We made adjustments for age, sex, smoking, HDL, LDL, systolic and diastolic blood pressure, and the presence of diabetes. And when we did all this, we found that there was really no increased risk for the group of patients with subclinical hyperthyroidism, 169 patients. But we looked at the hypothyroidism, we find out that actually there is an increased mortality in a patient who have TSH between 3 to 6. So mild subclinical hypothyroidism. And we've adjusted everything that stayed statistically significant difference. Of course, there's limitations to our studies. We only have TSHs. We don't have T4 and T3 values. This is high-risk patients, so you cannot, generalize to other population. And of course, we cannot determine the cause of death of these patients because we just did it from the Social Security death index. That's all. So, but, they suggest that at least in a high-risk population, that even the TSH higher than 3 may be associated with the higher mortality. Now, this is from another study published in 2012 that actually looked at the cumulative incidence of atrial fibrillation in relation to thyroid function. So in the green, you have normal thyroid levels, and if you follow patients, some of them will have AFib. But if you have subclinical hyperthyroidism, then your risk is a little bit higher. And if you have a low TSH and a normal T4 over here, it's increased risk. But if you have low TSH and high T4, there is even higher risk. So even subclinical hyperthyroidism is associated with increased risk of atrial fibrillation. On the other hand, subclinical hypothyroidism is actually associated with a less atrial fibrillation. And even if you have a full-blown hypothyroidism, there is a clinical hypothyroidism, then the risk is even smaller. So apparently thyroid function does have a measurable, significant effect on thyroid function. So what happens if you treat people with subclinical hypothyroidism? Now, it's hard to measure this effect, because most of them are subjective. But if you do psychometric outcomes and hypothyroid symptom scores, in double-blind randomized trials, you seek improvements consistently if the TSH is higher than 10 millions per milliliter. So if you have TSH higher than 10, it's almost no doubt there is a benefit. There's measurable benefit. But if you look at the cholesterol, T4 treatment decreases total cholesterol in the patients who have initially high cholesterol levels, whose initial cholesterol levels are over 240 millimoles per liter. They will decrease LDL cholesterol and apolipoprotein B 100. Cardiac function measures. Cardiac output increases if you treat. Vascular resistance decreases if you treat subclinical hypothyroidism. Mean arterial pressure decreases. Carotid intimal media thickness decreases over time, and diastolic and systolic function improves. So there is a measurable benefits. So what is the bottom line? Should we treat these people or not? Well, I do treat individuals with subclinical hypothyroidism if they are associated clinical symptoms that could be explained by hypothyroidism, or they're positive thyroid autoantibodies. Reason, as I said, treatment is cheap, it's not harmful. You assess the clinical laboratory response in 2 to 6 months. Actually, I started doing it even faster now because clinical response, the patient feeling, is actually within like 10, 15 days. So if they ask them to call me and let me know if they benefit, and if they did, we will continue treatment. If they say they didn't benefit, we will stop the treatment and assess it again, because at that moment, some of the patients will say, whoa, slow down. I didn't think this was helping me, but now when I stopped it, I think this really was helping me, and I want to restart it. And then, discussion is made with the patient. Do we continue or not? So I would treat most of these patients, give them a trial of treatment and see if they respond. Now, subclinical hyperthyroidism on the opposite side, most of them actually are iatrogenic. Because about 1/4 of patients taking T4 may have low TSH. And the reason for this is that people actually try to maximize their thyroid dose frequently in effort to lose weight, in effort to feel better, to have better energy. And a lot of doctors are going to give into it. And then we have also people with thyroid cancer in whom we intentionally overtreat a little bit. So this is something that have to be kept in mind. And also, people will sometimes have a spontaneous hyperthyroidism. And then those are the people who actually have to be investigated further. And those will either have a history of head and neck radiation that might be actually associated with hypothyroidism, and then presence of nodules of goiters. Frequently in elderly people, you will have a little suppressed TSH. Uh, so TSH should be suppressed, but not completely. It should be undetectable. It has to be detectable. Once the TSH is completely undetectable, you all seriously have to think about, full-blown clinical hyperthyroidism. But also you have to, again, keep in mind that there will be some transient fluctuation in TSH levels. So again, I mentioned effect of medications, steroids, domperidone, effect of non-thyroid illness, acute thyroid, early pregnancy, recovery for hyperthyroidism, and central hypothyroidism. So these are again, repeating those cases when the TSH could be suppressed, but there will be no hyperthyroidism. So other than iatrogenics, we will frequently see subclinical hyperthyroidism in the cases of the autonomous secretion of the thyroid hormone from the thyroid nodules, either solitary thyroid nodules or part of the multinodular goiter. And if you see 22% of the patients with multinodular goiter who are found to have subclinical hyperthyroidism. And if you, in hyperthyroid patients over 55 years of age with multinodular goiter, 57% of them were subclinical. They were not clinical. So multinodular goiter is a common thing. Graves' disease, about 6% of patients with Graves' disease are subclinical. And then there's thyroiditis, Graves' disease in a remission, and high HCG. Again, in the beginning of the pregnancy, you're going to have high HCG, and it could be as high as to cause true hyperthyroidism. What is the epidemiology? Reports of the prevalence vary from 0.7% up to 12.4%, which is insanely high. I don't believe this was good data, but that's what it's published. Enhanced 3 showed a prevalence of 0.7%. Smokers had 2 times higher prevalence, 1.4%. Another study found 1.8% TSH of less than 0.1 in the United States. In England, 6% had TSH less than 0.5. So as you can see, the study is actually very heterogeneous. They're actually determining the levels of TSH, on their own. They're very, very variable. So what is the natural cause of the hyperthyroidism? As remember, subclinical hyperthyroidism normalizes in about 10% of cases, but this subclinical hyperthyroidism actually eventually normalizes in 40 to 60% of the chances, and only about 4% progresses to overt hyperthyroidism. So, being patient with this might not be a bad idea. What are the clinical consequences? Well, the study looking at the bone metabolism, there's really no good data on fracture rates for these patients, but meta-analysis found a decreased bone mineral density, but only in postmenopausal women. And in those taking T4, low bone mineral density was found only if daily dose was higher than 1.6 micrograms per kilo per day. So we say that the full replacement dose of the T4 for the hypothyroid patient is 1.6 micrograms kilo per day. But if you go higher than that, you're running risk of decreasing bone density. And markers of the bone turnover have been reported to be increased in patients with a subclinical hyperthyroidism. Cardiovascular effects, atrial fibrillation. I already showed you some data on this. Prospective study of 2,000 adults over 60 followed for 10 years. If the TSH was less than 0.1, there was 28% cumulative incidence over 10 years of atrial fibrillation. TSH was 0.1 to 0.4, 16%, higher than 0.4, 11%. So clearly, decreasing the TSH increases the risk of the atrial fibrillation. There's another study, cross-sectional study, 24,000 hospitalized patients. Overtly hyperthyroid patients, 14% had atrial fibrillation. In a subclinical hyperthyroidism, 13%, but in euthyroid controls, 2%. So in this study, subclinical disease was as bad almost as overtly hyperthyroid disease. Then other described effects. So the study showed the increased heart rate and atrial premature beats, reduced excess tolerance, increased cardiac contractility, increased left ventricular mass index, and then lower LDL cholesterol and total cholesterol and systolic hypertension. Remember that in hypothyroidism is diastolic hypertension. Here is systolic. Looking at mortality, you have the study from 2007, 3,000 patients, subclinical hyperthyroidism associated with 2.32 times increased risk of cardiac death. So significant increase. Meta-analysis of 290 subjects over 60 found 41% increase in all-cause mortality. And cardiovascular health study found actually in 3,000 patients no increase in mortality. So again, we have heterogeneity of the outcomes, but there is a possibility of significant increased risk. So most individuals who have TSH that is higher than 0.1 microunits per milliliter do not experience any symptoms. So we know this from the patients with thyroid cancer. So the people, as long as you keep the TSH over 0.1, there's no really symptoms, very rarely. So how do you manage this? So these are actually the thyroid guideline, American Thyroid Association guidelines for treatment or not treatment. They were published in 2016. Those are the latest guidelines we have. So age of 65 is considered a risk factor. So if you're older than 65, your TSH is less than 0.1, you should treat those patients. But if it's TSH of 0.1 to 0.4, consider treating. You don't have to, you can watch. Now, if you're younger than 65, but also have comorbidities such as heart disease, osteoporosis, you're postmenopausal, not on estrogen or bisphosphonates, or you have hyperthyroid symptoms, you should treat if the TSH is less than 0.1 and consider treating if 0.1 to 0.4. But if you're less than 65, you have no risk factors and you're asymptomatic, you're not high risk, and your TSH is less than 0.1, you don't have to necessarily treat, but you should consider treating. And if your TSH is 0.1 to 0.4, you should observe. I would say that one of the things that is missing from these guidelines is, what are the comorbidities? You have heart disease, osteoporosis, postmenopausal symptoms, but excluding diabetes. Now, I believe that diabetes is an equivalent risk factor as heart disease, and you should consider treating people with diabetes in the same way as these other patients with comorbidities. So I would add diabetes to comorbidity list. Now, on the other hand, treatment is associated with significant risk of the side effects. So you have potential risk of agranulocytosis if you treat with PTU or methimazole. You have a danger of the liver injury, methimazole and PTU. Now, there's a difference here. Methimazole is associated with cholestatic liver injury, so you're not going to have liver failure. And the PTU is really increased, associated with a serious liver failure, leading sometimes to death and liver transplantation. Hypersensitivity is seen in many of these patients, and all of these medications, they will have rashes and so on. But and actually cross-reactivity is about 50%. So if you have a reaction to one medication, there's about 50% chance you're going to have a reaction to other medication. ANCA-positive vasculitis was described with PTU. So decision to treat is not easily made like in subclinical hypothyroidism. Here you have to really weigh the benefits and risks. And again, there are some remaining questions that we really don't have a clear answer right now. So what is the appropriate normal range for TSH? Well, answer will require more studies. They will need to include antibody determination and more than one determination of TSH of period of time to avoid transient elevation to creep into the normal ranges. So we still have to actually do some work to determine what is the appropriate TSH range. Should we screen for the subclinical thyroid dysfunctions or disorders? Well, population screening is not cost effective. You shouldn't be checking everybody, but the testing patients with mild symptoms suggestive of hypothyroidism is not screening. So who do you screen? Who do you I'm going to check your thyroid regardless of your symptoms. So I think we should screen high-risk groups. So history of neck irradiation, those are the patients I would watch the thyroid function, pituitary surgery or irradiation, any medications known to affect thyroid, presence of the thyroid nodule or multinodular goiter. Those are, those should be screened. I don't think this is very controversial. But we need additional studies to see if we should screen patients with other autoimmune disorders. I do this with type 1 diabetics because about 10 of them will have 10% of them will develop hypothyroid disorder in a lifetime. So I do it, but I'm not sure this is the right thing to do. Unexplained infertility, previous postpartum thyroiditis, a refractory depression, so depression hard to treat, Turner or Down syndrome patients, and patients with obesity. Again, patients with obesity, I will check thyroid when I'm considering treatment for obesity because I don't want to miss hypothyroidism as one of the causes. Is the treatment benefit? Well, studies are kind of inconclusive, especially for the hypothyroid disorder. Patients with a mild laboratory abnormality should not be treated automatically. You have to think it, give it thinking, and give it a time. This should be followed in 3 to 6 months and reassessed. If even mild symptoms are present, the treatment should be offered. And long-term outcomes really do need studies. We don't have a really good data on long-term outcomes. Thank you very much. This is my presentation.